All right. Hello, everyone. I'm Vincent Dachity, President and CEO of Mental Health Colorado. The Equitas Project is our national initiative to disentangle mental health and criminal justice. Thank you all so much for joining our virtual conference series on mental health, excessive sentencing, and the death penalty. This conference, hosted by the Equitas Project and the Eighth Amendment Project, has been offering 60-minute panels each day of the week this week to explore the intersection of mental health, excessive sentencing, and the death penalty. This is our last panel of the series, and we're going to get started out of step with the way we've been doing it earlier in the week. We're going to start off with a very brief 2-minute video clip that provides a little bit of context. So please join me for a few minutes as we watch this compelling bit of video.
It's time now, everyone. We're gonna do the Compassion Trauma Circle. Is everyone ready to face their past with compassion? Is that a yes? Yes! While you were growing up, during your first 18 years of life, if a parent or other adult in the household often or very often would swear at you, insult you, put you down, or humiliate you, step inside the circle. If a parent or other adult in the household often or very often pushed, grabbed, slapped, or threw something at you, step inside the circle. If a parent or other adult in the household often or very often ever hit you so hard that you had marks or were injured, step inside the circle. If you often felt that no one in your family loved you or thought you were important or special, step inside the circle. If your family lived in extreme poverty, step inside the circle. Step inside the circle. Step inside the circle. Step inside the circle.
There is no shame. There is no shame. There is no shame.
Did you know that if you live in one of the
Thank you for sharing that video with us, Dr. Patty Van Ace. Let me just, before we get started, make a few observations that I've been using to preface each one of this week's sessions. You know, among the nations of the world that we Americans generally hold to be our peer nations, the US is unique in our persistent use of excessive sentencing and the death penalty. We hope that as you join us for each of these panels that we've assembled, you've considered the 360-degree impact of our nation's attachment to torturous or nearly torturous punishment, inequitably administered, on the mental health of everyone involved, not just the individuals facing excessive sentencing, but also the jurors, corrections officers, prosecutors, defense attorneys, judges, mental health providers, advocates for social change, political actors, taxpayers, and all our children who so fervently want to believe and trust that ours is a just and humane nation. None of us who have our eyes open to the status quo of our system can experience the well-being to which we should aspire. And before we get started today, I want to thank Sarah McGee from TASME and Stephanie Fauché from the Eighth Amendment Project, who've been indispensable planning partners in pulling this week's amazing panels together. I also want to thank my colleagues at Mental Health Colorado, Emma Troten and Adam Goss, for all of their indispensable assistance. I want to acknowledge the very generous support for the Equitas Project's work from the David and Laura Mirage Foundation, and note that all of our advocacy work is possible only thanks to the generosity of our partners and allies like you. Thank you so much for your support. With that, it's my pleasure to introduce our final session, how trauma, adverse childhood experiences, and mental illness impact the brain and behavior. I'll be moderating today's panel, and our panelists today are Dr. Patty Van Ace, licensed clinical psychologist and expert on trauma-informed care and adverse childhood experiences. Judge Sheila Calloway, juvenile court judge in Davidson County, Tennessee. And Dr. Kim Gorgons, professor in the Graduate School of Professional Psychology at the University of Denver. Thank you so much for joining us for our final panel of the week. It's great to have you with us. So I'm just going to start. I've got some questions lined up here, and I'll start, I'll direct these at each of you as we go through this, but everybody has an opportunity to respond to each question. And folks who are participating online, please submit any questions that you may have for the panelists in the Q&A section, and we'll integrate those into the discussion as we're able. So I'm going to start off with my friend, Dr. Gorgons. Hi, Kim. Nice to see you. Thanks for being here.
Hi, Vincent. Thanks for having me.
So tell us, so how does early childhood trauma impact someone's likelihood of developing a severe mental illness?
It's such an important question. And even before I get started, I just want to shout out to Fritzi Horstman, who I think is one of the greats. And I've had the good fortune to get to see her in action. And thanks for sharing that clip. I think it's such an important place to start today as we talk about just how vulnerable this population is. And Fritzi's heart certainly is in the work, and she's an exemplar for doing it. Childhood trauma. How does it get you into adulthood and confer all manner of vulnerabilities? I study the brain, and I'm a neuropsychologist, a board-certified rehabilitation psychologist, and really importantly, exposure to particularly early childhood trauma, confers a biological vulnerability for the development of all kinds of poor long-term outcomes. Not only biological in terms of brain structure, so it doubles the risk that you'll develop a mental illness into adulthood. It also, as our understanding of genetics and genetic changes in real time, exposure to trauma also can change your actual genome. And I know we'll hear more about that from Dr. Van Ace also. If you look at directionally, first, for kids exposed to childhood trauma, I mentioned it doubles their risk of developing mental illness in adulthood. If you look in reverse, so if we look into some of our most vulnerable populations, the rate at which people have experienced childhood trauma is extraordinarily high. So for example, in the general public, if we define adverse childhood experiences at its most broad, that number is about 50%, 45 to 50%. In jails and prisons, that number is almost 100%. It's 97%. And it's about 70% in a treatment-seeking population of folks who present with any manner of mental illness. So we see where that trajectory takes you, and all of the intervening variables in the middle are where our attention is most focused. And we'll get to talk more about that today.
Yeah, thank you. And thanks for mentioning the video clip, which I found so compelling in my early, when I was first getting going working at this intersection. I visited Cook County Jail in Chicago and had the opportunity to witness exactly that same exercise in one of the units in the jail with about 35 young men. in there as they raised their hands repeatedly, going through a series of questions like that. And there's just nothing like that kind of immersion to open your eyes to what we're doing with our justice system. So Dr. Van Ace, thank you so much for joining us and for sharing the clip. Let me ask you, as a mitigation specialist who does ACE assessments for people on death row, what have you discovered about individuals on death row and the adverse childhood experiences?
Well, I think I've seen the culmination of the things that Dr. Gorgens just talked about. And I've assessed a number of persons, 20 some at this point, and I've assessed them very deeply. So I've talked with all of their family members that would be willing to have interviews. I've looked at many records, so I know the systems they were involved in as kids. And I've also done my own evaluation of the persons. And what I've discovered is that out of all the persons that I've seen so far, all of them had at least 8 to 10 of the original ACEs, the original adverse childhood experiences. In that clip, we heard Fritzy asking about maybe 4 or 5 of the ACEs. But out of those 10 original ones, we know that that for 8 to 10 to be apparent in someone, that's only 0.01% of the population has that many ACEs. So in the population that in my sample of persons that I've assessed, they all have had 8 to 10, except for one who had only 7. But it goes beyond that. First of all, we have these 10 original ACEs about child abuse and neglect, and also family dysfunction, like mental illness in parents, substance abuse in parents, domestic violence in the family, these kinds of things. But we've expanded our concept of ACEs recently. The Philadelphia study has added things like neighborhood violence and bullying and felt discrimination, whether that's racial or sexual orientation or any kinds of felt discrimination. These have been studied and added. And Dr. Nadine Burke-Harris in California has created what's called the ACE-Q for children and the ACE-Q for teens. She has the 10 original ACEs in there, as well as new ACEs, things like being in foster care. That one also came out of the Philadelphia study too, but foster care, medical trauma, death of a parent, separation of a parent through deportation or immigration, romantic violence, dating violence, and also being detained or arrested or incarcerated as a youth. So we've expanded our understanding. And what I have been doing is I've been using sort of that full set of ACEs. But when I tell you 8 to 10 for these persons, those are the original ones. Then I add on these new ones that have been, seen as having the evidence that they can predict. They can predict mental illness. They can predict incarceration in terms of the risk involved. So now my guys that I've been assessing have, 13, 14 ACEs, sometimes more. And another important feature here is that we talk about not only the number of adverse childhood experiences that accumulate, but how much toxic stress was experienced through those adverse childhood experiences. And as Dr. Gorgens said, that early life experience from birth to age 5, particularly birth to age 3, when the developing brain is making over 1 million neural connections per second. Imagine the plasticity, the molding of that brain. And if that young brain is not safe and is living in sort of what I call survival terror, because the needs aren't being met for the child, they're fully dependent on their caregivers. If they're in survival terror, their brains develop differently. As Dr. Gorgens said, structurally differently, neurochemically differently. They have a different brain. The guys that I've assessed have different brains. 2 more things I'll say about what I've learned. They haven't had protective factors like an adult who is fully invested in them. They have not had opportunities through our services that have really helped them, like somebody in education figuring something out that would help them. Child protective services. Many of these guys have been in foster care, but it wasn't helpful for them. So our systems have let them down, and almost all of them have been through juvenile justice that I have assessed. Maybe only one hasn't. And so then their identity gets formed as a team around I'm an inmate. I'm bad. I'm a thug. I'm a this. I'm a that. Their identity gets formed, and the brains of teens are still really in formation. And it's a time to jump on that. But I have learned that these guys want to understand themselves. They're grateful when we connect the dots between what happened to them and what they've experienced in life. They are thankful. They write me thank you notes. Their families understand and connect up with these guys in ways they haven't before. They say sometimes, I'm ready to die now because I get it. I've let go of my shame, just like that clip showed. So those are a number of things that I've learned, and there's more that we can talk about later.
Well, thank you so much. And before going on, just as a follow-up question, could you elaborate, because you said a little bit about this, but just elaborate a little bit about how failing to address those adverse childhood experiences can lead, create a pipeline toward incarceration and system involvement?
Yes, absolutely. So our brain is always in development. Even when we're our ages that we all are, we have what's called neuroplasticity. We can still make changes in the brain. It's harder. Just think about learning a language when you're 4 versus a new language when you're 25 or 30. It's a lot harder because our brains are not as open to making those neural connections, but we still can. So the younger we can pick up on these kids that are sitting in school, let's say, and their brains are in survival mode. They can't learn when their brains are in survival mode. They are distracted, they are zoned out, they are dissociated, and they're ready to fight or flee. They're not learning. Somebody's got to see that. And they need to pick that kid up, scoop that kid up, and begin to figure out what's going on with that child. So that's not happening. I don't think we're screening our children well enough, even in pediatrics. They're all the caregiving systems. What about early, care centers? But our foster care system, which I have been a very integral part of, I've worked in our foster care system, and I, have tried to help a lot of kids, but the system is foundationally not a good idea, because children need to belong, and children need to feel like they have an invested adult that sees them through their stages. So that's a system that's not working well. And I'll let Judge Calloway talk about the juvenile justice system. That's another system that we know needs improvement, right, Sheila? We've worked together before, so we can know what we know together. But I think it creates we aren't picking kids up and giving them the help they need. We're also, and that brain can be changed so much along the way, especially with invested adults and mentors. So that's the main thing. We've got to, it needs to be more of a priority. Like during COVID, it was a public health crisis. Everybody's got to wear a mask, right? This is a public health crisis, and we're not framing it that way in our nation. We need Dr. Fauci saying, our kids are in trouble, and here's what you need to be looking for, and here's what you need to be doing, and here's where we need to be putting money. So let's send 33 million or billion or however much we were sending to the Ukraine today. Let's send that to our child protection too. That's my soapbox.
Great, thank you so much. So turning to you then, Judge Calloway, tell us a little bit about innovative programs that you've been implementing as a juvenile court judge, and particularly around addressing trauma, and what impact have you seen?
Yeah, thank you for that question. And thank you for just allowing me to be a part of this magnificent panel of these wonderful doctors. I had the opportunity to learn from Dr. Patty probably about 10, 12 years ago, about the brain science and everything that our children face prior to becoming the juvenile court judge in Nashville, Tennessee. And so for me, understanding what she was saying, learning more about adverse childhood experiences, learning about how our youth deal with trauma and how that affects their brain development meant that we had to do a different system. And that the system that we were operating under, where a child who probably had experienced much trauma when they came to us with a delinquent offense or something that brought them to the juvenile court system, that it wasn't sufficient to say, okay, well, now you have to either, lock you up in a treatment facility that's supposed to rehab you and send you back out, or send you on probation with a bunch of rules and check boxes to follow, or send you to the adult system and good luck there. I had to do something different because that was not going to help any of our children. And we've had histories of data that proves that that does not work. And so for me, we had to do more for the core of our youth, working with their families, working with every part of the community to make people understand that what we do to our youth from 0 to early on, prenatal on a totally affects what happens to them later on. And so we have done a lot of different programs on different parts of our court system to make a difference. One thing is we are proud to say that we were the first jurisdiction in Tennessee to have, at the first it was called an infant court, now it's the Safe Babies Court. There are 14 now in the state of Tennessee, where we literally, from a time where a child may be removed from a parent due to neglect, dependency, or abuse, or even if they're at risk of being removed. So we can do it even if they haven't been removed, but there's some factors that have brought them into the eyes of the court system. We work with that child, that family. We build a village for that child and that family, so that it's not sending people referrals, go over here and figure it out, but it's actually holding hands. It's actually making sure that people understand what it means to help that child build resiliency and what it means to help that child be successful and to overcome the traumas that they have faced. We have a lot of success with so far, I mean, I can't say that the children are not coming to the system as delinquents yet because they're still babies. We've only been doing it for maybe 4 or 5 years now. And so they're still in that age, but we've had success in getting children placed in very supportive, nurturing, loving families, whether it's a return to their parents with literally holding their hands and having their village be with them the entire time, or whether it is adoption with a family that understands the trauma that they've gone through. So we've had a lot of success with our Safe Babies Court. In Tennessee, we have the opportunity not just to have juvenile courts that deal with children that have committed offenses, but we also deal with adults. And literally 2/3 of the cases that we handle are about the adults and how they are responding and acting for the children. And our job is to figure out what's in the best interest of the child. And so as we're working with adults, whether it's an adult that is alleged to have abused or neglected their child, or whether it's just two parents on a custody issue that are unable to decide custody decisions on their own and need the help from the court, we understand that it's at that moment that they need help understanding how their behaviors around their children, how their arguments with each other around their children lead to more trauma for their child. And so we have a parental assistance court, and our parental assistance court has court specialists, we call them our PACs, where they work hand in hand with their parents on trying to make them understand what their efforts are and how that makes a difference on how their child's brains are developing, and that we want everyone to have a healthy child in a very safe and secure atmosphere. And so we are proud of our parental assistance courts. They're all trained mediators. And so they literally work with the parents and making sure that they're doing everything that they can. We have referral programs that we work with different community agencies around the city to make sure that we are doing everything that we can to get them on the right track. We also do a lot with the recovery courts, both for our youth and our adults. And so adults who have lost custody of their children due to some type of drug and alcohol abuse, we are making sure that working for the best interest of the child, that parent is going through a recovery with hopefully connections with the child and making sure that they are doing everything they can to overcome not only their drug and alcohol addiction, but making sure that they understand the importance of positive parenting. And so we do a lot with our recovery courts. We do have a recovery court for youth who also have drug and alcohol problems, and making sure that we're working with them as well to overcome those addictions even if it's at a young age. And then finally, we do understanding the importance of assessing youth and making sure that we understand what we're working with and the framework and what they bring to us, instead of just having a random sheet of things that we're asking youth to do. We do a number of assessments. We do our CANs, which Dr. Patty can try and help me remember what CAN stands for, the Child and Adolescent Needs Assessment. We'll go with that. With our CANs, we do ACEs for all of our youth that we have that come to the system that need an assessment. We also do a developmental strength test, a 41 developmental strength test. I should have looked these up before I started talking, but all of these things are so that we know each individual child that we're working with, what we're working with. It's not enough. It's not a system that says, you know, if you stole a car, then you don't steal a car class, or you get locked up. It's a system that says what's happened to this individual, why are they here, and how can we support this individual to make sure that they are healthy, secure, and a loving atmosphere in our community. And those are some of the things that we've done to try and change the trajectory of our system. Our system, I think, as Dr. Patty said previously, doesn't work. It doesn't work well. It doesn't work to support the youth that we serve, or the youth and their families. And so it's my job each and every day to make sure that we are changing that system to make it to a system that literally is trying to help people overcome the traumas that they've had in their lives.
Thank you so much. Such impressive work in making the path toward justice. So Dr. Gorgons, tell us a little bit about traumatic brain injury and how traumatic brain injuries, whether it's from abuse or accidents, how do they affect mental health?
Vincent, I love this question, and I could talk about it all day long. So I will try, not to do that. I have worked in the brain injury field for my entire career, so 25 years now. I've been really fortunate to be doing this work in criminal justice for the last 10 or 12 years, and driving some of that research and policy work forward. And I think there's so much more work to be done. So with that in mind, just to give everybody a lay of the land, when we talk about brain injury, we have two kinds of brain injuries that ultimately have the same kind of net effect. One is a traumatic injury, which is the way we think about a blow to the head, an external blow to the head. And sometimes that might even be a blast injury. And we have what are called acquired brain injuries, which in criminal justice, in a lot of the settings for behavioral health treatment, for example, which include two high frequency base rate acquired brain injuries, strangulation, particularly for women, and folks who've had near lethal drug overdoses who, let's say, were resuscitated by Narcan, for example. They'll also have this cluster of really similar kinds of problems. I like to think about the biology and the biological consequences of injury because I think it goes a long way towards destigmatizing these outcomes that I'm about to talk about. So the immediate effect of injury is an inflammatory response. In this case, it's in the brain, so we call it a neuroinflammation. Importantly, chronic neuroinflammation is associated with changes in the shapes of the cells in the brain, changes in the function of the cells in the brain, changes then in the circuits, the function of the circuits in the brain, and ultimately changes in the structure of the brain. So you have structural, biological, neurochemical changes, all related to the original injury. The net effect for some folks, so a lot of people will sustain a mild injury and recover fully to baseline for reasons we don't completely understand. Some folks are more vulnerable to poor outcomes. Some folks are more vulnerable to poor outcomes even after a single mild injury, certainly for moderate and severe injury. But in any case, for some people, that chronic inflammation is related to all kinds of poor behavioral health outcomes and then ultimately community outcomes. So for example, the risk for folks post brain injury of developing a new onset mental illness. So for folks who have no history of mental illness whatsoever, their risk of developing a mental illness in the first 12 months is about 60%. So 60% of them will develop a clinically significant presentation, anxiety, depression, psychosis, even personality disorders. You see about that same risk for substance use. So for folks who have no substance use history, their risk for developing a substance misuse disorder is extraordinarily high. Importantly, from a behavioral health management perspective, the risk for suicide is extraordinarily high. We know in research that it's anywhere from 7 to 27 times more common in folks after brain injury than it is for the general population. You also see extraordinarily high rates in younger patients of school failure, academic failure, behavior problems. The piece of your question that I wanted to circle back to was injuries related to abuse. And there's something really unique about the kind of outcome that characterizes an injury related to violence. So those injuries are unique relative to the other kinds of injuries we've talked about. So there are unique vulnerabilities for folks who have, let's say, a child abuse related brain injury, or a brain injury related to interpersonal violence as an adult. So those outcomes are also poorer. I'll change gears just a bit to talk about some of our research on really vulnerable populations here in Colorado. When we looked at our statewide data, this in jails and probation settings, problem-solving courts, we evaluated about 4,600 men and women. What we found was that overall, there was about a 55% of that population had a history of significant brain injury. So not an uncomplicated, mild, get your bell rung kind the population base rate PS probably below 5% for significant brain injury history. It's 8.5% for all brain injuries. Importantly, though, for that group of men and women who had a significant brain injury history, who were involved in criminal justice, 94% of them also had significant substance misuse problem. 76% of them had a significant history of at least one mental illness. 100% of them had a history of suicidal ideation, and 40% of them had a history of attempting suicide at least one time. 62% of them had been suspended from school at least one time. 38% had been expelled from school at one time. We paint a really clear picture of an injury to prison pipeline in this population. And what we also found is that having a brain injury imparts a risk for poor judicial outcomes, so poor community outcomes, perhaps not surprisingly, a poor rate of compliance with recommendations. They're more likely to blow through conditions of probation and to stay on paper, and they're more likely to reoffend. So it perhaps from a clinical perspective, identifying someone as having a brain injury is a way to flag the acuity of the highest need people in a really high need population. So traumatic brain injury is a high stakes injury, and it is related to all manner of poor outcomes in the absence of intervention.
Let me just ask you too, I think that there was something, and this is kind of a follow-up, there was something in the New York Times about survivors of domestic abuse having head trauma more often than football players, and how rarely these are diagnosed. What are the consequences of how widespread this undiagnosed injury is?
Right. I so appreciate you following up on this population in particular, because I feel so strongly about this as a clinician, as a researcher, as somebody who's invested in creating good policy. I know this will be true of my colleagues here on the panel as well, that there's something so uniquely vulnerable about some of the women who are in our system. So for example, I already mentioned that violence-related brain injuries are associated with poorer community outcomes. So women in particular exposed to interpersonal violence-related brain injuries are less likely to recover fully to baseline, for example, and more likely to have poor outcomes like community assistance, for example. So public sector income sources 12 months after their injury. If you think about the scope of the rate at which women are exposed to interpersonal violence, it starts to like really paint a jarring picture about the scope of the problem. 1 in 3 women are exposed to interpersonal violence. And if we just look at the last few years mid-COVID, the rate of law enforcement involvement in interpersonal violence cases escalated by 300%. So the rate at which the vulnerability of women to interpersonal violence escalated in the last few years really is unknown, but every piece of data we have suggests that that it was really grim, and it's been grim. Importantly, 92% of women who are exposed to interpersonal violence describe blows that include being hit in the head, being hit in the face. 42% of women describe also being strangled at some point in an episode of interpersonal violence. In some research that we're doing here in Colorado with partners at the Rose-Andom Center, which is a multidisciplinary intervention site where we have all hands in one building, childcare, healthcare, legal services, law enforcement, mental health care. In that partnership with the Rose-Andom Center, we've identified about that frequency. So among women who are presenting for care after an episode of interpersonal violence, about 90% of them have experienced at least one significant brain injury. About a quarter of them were strangled in their most recent episode of interpersonal violence. And most of them had experienced a period of time where they had multiple injuries in a short period of time. And I make the point in a TED Talk that I was fortunate to get to do on this issue, that these women look like retired NFL players without the benefit of liability coverage, certainly, or high profile media attention. So the rate at which women sustain brain injuries, hundreds and thousands of brain injuries over the course of a lifetime, really the effects of that cannot be overstated. And the vulnerability for those women to poor outcomes is, I mean, we'll see it play out in the next few decades if we don't intervene better, but it is set up to be a tidal wave of really catastrophic consequences.
Well, thank you for that. So Judge Calloway, what's been the most frustrating aspect of hearing cases that involve untreated mental illness and traumatic brain injuries and adverse childhood experiences?
Yeah, for me, the most frustrating thing about it is that if I know that if someone in systems well before it came to the court system had understood what they were facing or understood what was going on, then that child would not be in the court system. And so that is truly frustrating. We can look back, after the child has done a serious offense and they're in front of me looking to go into the adult system because of the charge that they have. You can look back and get all the records, get all the school records, any, potential counseling records, whatever it was that child was facing. And you can absolutely see the gaps in our services in our community. And it is extremely frustrating. There's one of the most severe cases that I've had, which was a murder case that a child was involved in. That mother in that case was reaching out for help when that child was 1 year old. And of course, the place that she reached out to said, well, that child is too young for any type of services, so we can't do anything at this point. And, time and time again, when that mother knew that something wasn't quite right, and a mother who did not have good insurance, did not have just a wealth of knowledge of how you deal with mental health, was counting on the little services that she could get her hand on. And at every point, it felt like she was getting turned away. And the child's behaviors, even at a baby, were aggressing and becoming worse, or progressing and becoming worse. And so it did not surprise me, looking through the history of the records, that she ended up in the court, or the child ended up in the courtroom with a very serious offense. There are so many of our youth who get lost in the school system, who obviously probably should have had some type of IEP, some type of testing, but yet they were either just held behind, just thinking that they were not applying themselves to the schoolwork, or they were treated in a negative behavioral manner, whether it was suspended or expelled from school, when literally it probably had something to do connected to mental illnesses that were going untreated. And so it's frustrating when we see where systems has failed, and it gets to the point where a child is committing serious delinquent offenses and has to come into the court system. And then once we're in the court system, there's so many other frustrations that I have to deal with. If I'm able, not to send a child to the adult system, or able to do something while they're in the community, and not, put them in any type of facility or the foster care system, or a youth development center, if I can keep the child in the community, I still have issues because, right now it'll take about a month for that child to have an intake for a mental health assessment. And then once they have the intake for the assessment, then it's going to take a long time to get an actual appointment and to bond with a therapist and to get to that point where they really are able to start the process of learning and growing. And so it's difficult. Even if I have that ability to do that and do it in the community, the resources are so lacking. The places where I can send children is unfortunately a huge frustration. And then if I can't do anything in the community and that child ends up going into the custody of the Department of Children's Services, there's still a void in the services that they can give in the department's care. And I think Dr. Patty kind of mentioned it earlier, and she did it very strategically and politically right. But once a child goes into a foster care system, they're one in Tennessee, one of a 900 something children who probably are going to be on some type of waiting list, a waiting list for services, a waiting list for placement, just waiting and languishing in care. And, it's not the department's fault. It's not the court's fault. It's not the school's fault. It's just so many holes in all of our systems that we are not able to plug those holes, and we are losing children on a regular basis. And so those are some of my biggest frustrations. I've really, a lot of times, feel like I don't have the ability to really help where I can. And to me, to be the judge and to be the one that's supposed to make these things better for our youth, and to have the statutes say that it's my job as the court system to provide for the wholesome care and nutrition, educational, welfare, health of these children that come into my jurisdiction. The fact that I know that I can't is super frustrating. And I want to make sure that each and every one of our children has every opportunity to be successful. And sometimes I just don't have that ability to do so. And that's why I get frustrated.
Thank you. So in terms of those, so Dr. Van Ace, maybe you can answer this question. Those kinds of gaps that Judge Calloway is mentioning, what are the sorts of programs and initiatives that could be implemented, including in rural areas, to identify and address adverse childhood experiences and trauma and mental illness in children and teens in order to get them help and avoid the kind of system involvement that leads to more difficulty?
Yeah, well, starting young. Sheila mentioned the Safe Baby Courts, which is a fabulous initiative that can be in rural counties, just like it can be in urban counties. And it is a fabulous model that we could also bring to older children, in my opinion, because it's about bringing that village around each child, having the people that they belong to at the table, having their parents or their kinship people, whoever they belong to, at the table, so that when a decision finally makes itself known because they've tried treatment and they've tried to figure out where is the child going to thrive best, even if it means the child goes to a different family that is embracing them to belong with them, the family that they come from has been part of the decision. And the trauma is greatly mitigated because remember, foster care is a trauma now, it's an ACE. And we can mitigate the process of that by making it safer, making it more collaborative, helping children see that they're being heard, that their parents are being heard, that kind of thing. So starting young and getting our systems together with those kinds of initiatives makes a lot of sense. Doing assessment early on, having each school be trauma informed so that they know what they're looking at. So they're not saying that child's a behavior problem. They're saying, I wonder what's going on in this child's life that is causing this kind of behavior, because kids do the best they can with what they've got. We all do. I mean, think of us. We get up every day, and some days are bad days, or maybe something really bad has happened with in our life. We're not the best behaved people that day, and kids in chronic stress situations are becoming cumulatively unsafe. And so we have another big sort of umbrella thing is let's make our systems all safe and our schools safe. And if we can think safety, that's where kids and older people too can heal. And there were some questions that came through the Q&A about the neuroplasticity and what about, can people really heal? Can the brain really change? Or is it just, by the time they're adults, is it just entrenched? What we know is that we can change the brain. We are learning more and more about that, even when we're older. So if we can change it younger, we're better off. Children need to learn how to feel safe on the inside. They need to learn how to breathe and be present. And that can only happen, those new neural pathways can be made only when they're safe. Healing only happens when they're safe. So that's one thing. Another thing I would point to is that ACEs, through the toxic stress, causes the inflammation that Dr. Gorgans was talking about. And it also sort of knocks out our immune systems, makes them weak. And so we're all prone, if we've had a lot of ACEs with a whole lot of that toxic stress, so high doses of the toxic stress, then that's how our health gets poor. That's how we get more heart disease and cancer and diabetes and sort of inflammatory related diseases, autoimmune diseases. But it's also how we get anxiety, depression, PTSD. All of that is coming through those same kind of systems that are being activated by that toxic stress. So then what happens to our young people is they turn to something to quell the stress, to make them feel better. And then we get into the substance use disorders. And I didn't say this, but everybody I've assessed on death row has had substance use disorder issues. And so they go together because people are trying to take care of this stress and they're not safe. And so a system that we really need is a system that will catch the kids before they fall into the substances. Getting them when they're teens, they're probably already there. Let's do a safety net down when they're, young children, when they're 5 and 6, better if they're 1 and 2, better if they're prenatal, and support the parents. So let me see if I had anything else to wonder about there. There's a prison in Norway called Bastøy. I think most of you probably know about it. And that prison has a 16% recidivism rate for the first year back into society. And what they've done there is they've made a safe environment that respects the human being. Rather than isolating and dehumanizing them and incarcerating them, they live in cottages. They do the things that bring them joy, like take care of the animals, do the woodworking. They contribute to their community. They make meals together. They socialize together. It's on an island in Norway. And it sure beats the 46% recidivism in the UK, which is a close type of population. And ours is like 60% recidivism in the US. So I would say anything we can begin thinking about. We have something in Nashville called Thistle Farms, which is a social enterprise for women who have been involved in prostitution and drug-related offenses. They've all had histories of adverse childhood experiences. They're taken up and they're brought into community with other women, and they are given jobs and taught skills, and they work together in this beautiful community. These are the kinds of things that restore humanity and hope. And those are the kinds of interventions that I would think about for our kids too, not just therapy, not just mental health, but what makes them thrive and feel competent and have an identity and belongingness.
Thank you. And to ask, do you think that all of these sorts of earlier interventions would end up being less costly than our current practice of prosecution and incarceration?
Absolutely, it would. There's some study by Heckman, and I wish I could recall the numbers on that, but it's on the Harvard site for the developing child. And it's a public policy kind of look at if we put $1 in for, like each dollar reduces the cost of, special education and incarceration and drug-related medical issues and all of these things and accidents. But we do believe that the return on investment can be very great, but we haven't really tried it. Back to the urgent public health issue. What we do with urgent public health issues is we put lots of money and we say, we're going to really put lots of money into AIDS, into HIV virus, so that we can, do something about it. We're going to put a lot of money into COVID so we could do something about it. Yes, it would save us money. There's a lot of downstream money that we're spent, and even death row, think about the cost there. It's enormous.
Thank you. So we're going to be running out of time shortly. Let me just ask you and start off with you, Judge Kelly. What do you think the biggest obstacle for policymakers is to move toward a trauma-informed care model rather than the model of retribution and punishment that we have in criminal justice?
Yeah, I think the biggest obstacle is dealing with the public skepticism or the public disbelief and understanding that the retributive method that we have in the criminal justice system does not work. People honestly believe that when they say we want justice, that they think that locking someone up for the rest of their lives or giving them the death penalty equals justice. And what they don't realize is that it's not what it is, and that's not what happens. We have to educate people on the difference between accountability and punishment, and have to educate people on what it means to have trauma, to have adverse childhood experiences, and how that affects people's brain development, and how people can absolutely change. And there was a question, I think, earlier, how do you get judges to say, just because someone has brain injuries, untreated mental health issues, that means we got to lock them up longer because that means they're going to be riskier to the public. What we have to educate judges and the public is that, no, if we put the proper resources with this person, they may not be another risk to the community, but we have to do the work. We have to work with them. Even as an adult, we can still work with them, and we can still get them to the point where they understand what their triggers are. They understand how their brains develop differently, and that if I do this type of activity, this is going to trigger this type of behavior from me. We can work with people and help them to understand that. We have got to educate everybody, not just us that's on this call that already know the issues, but people outside who don't believe us. And the one thing that really helps people understand is if you have data to back it up. And one thing that the criminal justice system and the juvenile justice system does not do well is keep data that's appropriate and that can help the argument. So what I absolutely know is when I looked at the number of youth that we were sending to the adult system, the reasons that they started in the youth system was because of parental actions and things that their parents weren't doing. And so I'm sending 90% of the youth that go into the adult system are started in our system because of something that happened to them. And so if I know that and I have the data to show that, I can change that. I also know that the youth that I put in the Department of Children's Services custody as a delinquent child, with the hope that they're going to be restored and rehabilitated, that 80% of them keep coming back for a second offense after they're released. And so we have a horrible recidivism rate with youth who are going into these lockdown facilities that are supposed to be treatment and rehabilitation, where on the opposite end, I have good numbers that show that our youth who have committed a felony offenses that are going through a restorative justice program, our recidivism rate right now is about 1%. Now it's early in the process. We haven't been doing it very long, but only 2 of them have come back out of the 60-something that we've gone through the program. So if I have these proof that this works, this holds a child accountable, this helps a child understand what they've done and that they should not do that type of behavior again, or will lead to this type of process, versus all of these other kids that we've been locking up, they're coming out and doing the same, if not worse, offenses. Why do we keep locking them up and thinking it's going to get better? And so we have to educate the community with the data that we know is going to change our system. And we have to remember that, most of the policymakers are elected officials. And a lot of elected officials are going to conduct themselves in the manner that they think they will get reelected because they like their jobs. And so we have to be more careful on who we elect, and we have to elect people who are going to do the right thing, regardless of people say, lock them all up. We have to have judges who are willing to say, I'm going to do what I believe is right based on the data, based on the science, not based on the public's belief that justice equals incarceration. And that's what we have to start doing.
Well, that sounds exactly right. And I think that that's making sure we're educating the public and electing the right people is a good final takeaway message. And we're at time. We have so many questions in the Q&A, but we we are at time, and I just wanted to thank the three of you so much for being with us this afternoon. And this is our final panel of our summit series. This has been recorded. All of the panels will be available on our website at mentalhealthcolorado.org going forward. I just wanted to mention that we're going to be holding a virtual summit series in late May, starting in late May, on 3 consecutive Fridays, focused on rural and frontier communities and their efforts to do mental health diversion. And I guess I just give you a few seconds, panelists, if you'd like to type in any answers to any of the questions in the Q&A before we wrap things up.
Yes, I've been typing a few things and other people can contribute too. Trying to see.
Vincent, while she's saying that, I was going to give a shameless plug. If you're in Nashville and you're a voter, I am on the ballot.
I'll vote for you, Sheila. I'm in your county.
I want to relocate there just to be able to vote for you. That's amazing. Good luck. Boy, the world needs you right now. We really do.
Thanks, I appreciate it. It does help them unopposed. So.
Somebody's asking about really how do you talk with the in testimony, how do you combat testimony that kind of says this is hardwired and this person's going to be a menace when they get back out there. And I think one of the things you can say is, this is one of the things I've discovered with my assessments, is that, you know, we owe these people, we the state or we the county or we the whoever, we didn't meet their needs. They are victims too. They're all victims. I have a little quote I meant to say, that these people are, I always see an untreated, traumatized child living in the body of the teen or adult that I'm assessing. An untreated, traumatized child. They didn't ask for that. So one of the things that I sometimes remind the court is that we, like maybe I'm in another state often, this state did not meet their needs when they were coming through the child protective system. They got passed on to an abusive family and another abusive family, for example. We owe them something back. Let's give them a chance to get healing. Let's give them a chance to change the way their brain operates by connecting the dots and doing trauma treatment, trauma-specific treatment. And let's help them regain a core sense of stability and trust that they've lost through these years. So I think, Julia, I didn't get that typed in, but that's one of the thoughts I have. I don't know if other people have those thoughts, have more thoughts.
Totally agree.
Yeah.
That's what I love about the whole of the field of neuroscience. It's so inherently optimistic for just the same reasons. And these models of delivering care are ways to promote accountability. And it really is, frankly, the only way to promote accountability is to give someone the tools and the treatment necessary to address all of those challenges. Yeah.
Yeah. And again, I point to Bastoy, you all, if you don't know what they're doing in Norway, it's interesting to see because they have a low recidivism rate. The facts are there. There is some evidence. And our punitive way doesn't.
That's right.
So.
Well, thank you so much. It's a good sign when the panel doesn't want to wrap and the folks are still on the call, but we're going to call it quits for today, and we'll hope to have you all back together again at a future opportunity. Thank you so much for the work that you're doing and for your participation in this summit series.